an introduction to psychology for counseling students at a fairly basic level. Okay, why do we need to study psychology? Because psychological theories form the foundation of counseling, which we are going to learn during the next 1 year. We will be discussing many theories, but there are so many things which are common to all these things. That is one thing. Second thing, we don't need you all to study them to a very great extent as you do in a psychology course in the university. But we have to have some idea in order for us to use them and understand students. These theoretical ideas are mostly coming from the West and were formed during the last century or so, and important for us to learn. But when it comes to counseling, there is a related concept called psychotherapy or clinical psychology, which we consider as a slightly advanced kind of a study area. So we do not expect you to study that much of psychology, but to understand some of these things. Basically, when it comes to counseling, psychology, and psychiatry, everything in modern science, we believe that the mind is inside the brain. I don't know where exactly it is, but in science, we assume that mind is a function of the brain. It is not the function of, let's say, a lung or the kidney or the liver, but the brain, right? When it comes to the brain, we have studied brain to a very great extent. When you read certain theories in biological psychology, you will come across different words. Like this is a very commonly used concept which we use to describe certain emotions. For example, feeling happy, contented, and pleasant. So pleasurable experiences are supposed to be mediated through these sort of pathways. Specifically, we identify it as a dopamine pathway, and it's fairly complex. We don't want you to grow this, so or at least, well, of course, you will have to remember this. Everything is biology based and brain based, but it goes beyond what we can describe using biochemistry. I will give you an example. For example, most people believe that when we drink alcohol, we become happy or happier. And then when the biochemists, or rather neurochemists or neurophysiologists, looked into the brain, not of humans, but of basically lower forms of animals like rats, they found out that at some point, alcohol will trigger off a reaction which will increase what we identify as dopamine in this area, which is called the prefrontal cortex of the brain. And the reaction actually starts in this ventral tegmental area, or this part is called the limbic system of the brain. So biologically based reaction was identified and related this to happiness. And then various other forms of behavior related to alcohol use. So apparently there is a direct connection between feeling happy and alcohol use, because that is what the hard sciences like anatomy, physiology, biochemistry tells us. However, it is not so. If you give alcohol without that person's knowledge to a person who is not a habitual drinker, දවස ගානේ බොන්න නැති හැබැයි වෙලා නැති කෙනෙකුට ඇල්කොහොල් දුන්නොත් එහෙම යාට තේරෙන්නේ නැති වෙන්න ඩ්‍රින්ක් එකකට දාලා හරි එහෙම නැත්නම් සේලයින් එකකට දාලා හරි යකට විද්දොත් then he will not feel happy. If you give alcohol without that person's knowledge, then he will not feel happy. That expected behavioral reaction will be not there. Why? Well, there are other reasons why this happens, but simply remember there is no direct correlation between the chemical or biochemical model or the description which we have come up with and the behavior which we elicit. Simply by removing the awareness of this chemical, you can change it. Right? We will discuss those things later when we come to deal with substance use disorders. But for the time being, remember, biological models of psychology is based on the function of the brain primarily. But having said that, I just gave you an example to understand that biology, biochemistry, and various other hard sciences do not completely describe our behavior. So likewise, there are purely psychological theories. One is the Freudian theory. So Freud in early 20th century started doing hypnosis. He was a medical doctor. Freud was trained in medicine, and then he started to practice as an assistant neurologist. And then he himself became a neurologist, and he was treating these patients with neurological conditions. Then he noted that among his clientele, the patients that he saw in Austria, Vienna, and even before that, there was a group of young, wealthy women, like whom we have in this course as well. Women, majority, and in the medical school as well now. So young, wealthy women, came with different kinds of symptoms: paralysis, weaknesses, abnormalities in sensation, and various other things. When he treated with hypnosis, which he learned from his teacher, he realized that these symptoms disappear. So he resorted to study this phenomenon and taking the trouble to identify the mechanisms and then how to change these things and improve, and later came up with the theories of psychodynamics. We will come to that. So this is a psychodynamic theory which is based on the assumption that our unconscious thoughts affect our symptoms and the behavior. So couch is very symbolic of psychotherapy, because initially in the beginning, Freud was just sitting behind the couch and allowed the patient to speak. That is what happened. And then all these unconscious things came out. Then he made various connections, and then symptom resolution happened. When it comes to counseling and psychotherapy, we have some problems. So now I discussed the biological model and then the psychotherapies, but from psychotherapy, then what is counseling? As I mentioned earlier, psychotherapy is at a deeper level, at a higher level of competence. And world over, a psychotherapist or a psychologist is identified as somebody who has had a longer training. So that's why we don't have 1 year diploma in psychotherapy. You can't find that frequently. If it is there, it will be for people who had done an MSc or something like that. So, but the problem is, where does counseling end and where does psychotherapy starts? In real practice, it's so difficult to delineate it. But we should say, at least when it comes to application of theories and techniques, counseling does not employ very sophisticated theories like psychoanalysis. But depending on the person who is doing it, he or she, if trained, can use various other things, right? So that is the problem. Can we learn psychotherapy on our own? Well, that is what Freud did, isn't that so? And that is what some of the psychotherapists who came up with later theories did. But can we learn it on our own? The answer is yes, we can. But the problem is it is not ethical to do so, because even Freud himself and subsequent therapists would have done a lot of mistakes and probably damage as well, or missed cases, misdiagnosed, treated in a manner which wouldn't have helped the patient at all, because they were doing that at the development of the history of psychotherapy and counseling. So we can't proclaim that we are self-learned psychotherapists and we are doing it in our own way. We have our own model of doing this. That is not ethical, because when human beings, the society, have discovered certain models and theories, and when they are proven to be effective, at least to some extent, it is unreasonable for a patient to undergo an experiment with a single therapist who believes that he can cure without resorting to already available procedures. It's like a surgeon trying to operate in his own manner. I know consultant surgeons do that, but they resort to that only at the very last moment when they find out that their usual, traditional, well practiced techniques are going to be useless. Let's say a situation where cancer is there, disseminated all over the place, then traditional demarcations or anatomical structures will not be there, that sort of things, right? Can we alter psychotherapy? Yes, at a very high level of expertise, not at, well, let's say your level. Then the other thing is, can we learn psychotherapy without supervision? That is what Freud did. He didn't have a supervisor, but we have to have, because that is where we are now. The system has developed to a great extent where people have practiced it and are capable of delivering an effective treatment without harming the patient. So when that is there, it's your obligation to learn this, learn that and practice, rather than experimenting on patient. So there are people out there who claim that they are psychotherapists and psychologists and sometimes psychiatrists even, who have not had a clinical training, who had not seen patients when they were in the training, but they have acquired certain qualifications and state that they can do that. That's damaging to the profession and that shouldn't be done. That discussion, we are brought to this picture, right? In good old days, I don't know whether you remember these things. If you all are very young, I can't see you. At least, of course, I can remember when I was a child, when my mother used to take me to the doctor. The doctors used to give us certain forms of medication in bottles. ඉස්සර ඉතා ඈත අතීතයේ මේ බෝතල් වල දාලා වතුර බෙහෙත් වතුර දෙනවනේ. බෙහෙත් වතුර කියලා අපි කියනවා. Of course, the Ayurveda is still practices that they have a lot of medicines in liquid form. In the Western medical system, we don't have, very rarely, unless you are a small child, you don't get liquid medicine. But those days it was a practice. So I'm going to tell you a story. Maybe this happened in 1940s, 50s, I don't know. There was a new intern doctor, a new medical doctor who just passed out from the medical school, came to work as an internist, house officer in a medical ward at the National Hospital. Then in his very first day, he was a good doctor. So as all of us did, carried a small pocket book and jot down what the consultant said, because by the end of the ward round, otherwise we would have forgotten certain things, because some of the things are not written in the BHD. So we remember to give certain things. So if we don't understand, we also got it down and then later clarified. So he did the ward round with the consultant. So consultant was going from one patient to the other, advising him to do various investigations, blood tests, urine tests, and then to give various medicines, including things like quinine. Those days quinine was available. for the treatment of malaria and most other fevers, antipa and various other medications which were in liquid form. So 1 ounce of quinine to this patient. Another 2 ounces of quinine to the next one. Likewise, he was sent. Then the third patient, he said, okay, 1 ounce of ADT. And the next one, again, quinine and various other things, some tablets as well, or just fomentation or referrals. Likewise, another patient, 2 ounces of ADT. So at the end of the ward round, usually once the ward round finishes, the consultant leaves the ward. So the house officers and other doctors and the nurses are left. So this young man was scratching his head to find out what does this mean. Now the consultant has prescribed ADT for 3 or 4 patients and he did not know. Now once you obtain your license to practice or MBBS or whatever, MD, you know that you are well versant in medical literature as well as you know the medicines which are commonly used. But this was new to him and he was puzzled. He hasn't come across this ADT in any textbook. So what did he do? There was no other option, but he went to the ward sister, who is a senior nurse, and asked the sister, sir said to give 1 ounce of ADT to that gentleman in bed 17, 2 ounces of ADT to that patient in bed 3. Do we have ADT in the ward? And sister and the nurses started laughing. Right? It was a very ridiculing situation for the new graduate in medicine to be the center of this drama. So he was really upset. But then he waited for a while and then sister said, the doctor, ADT, that medicine is not there. What ADT actually means is what? Any damn thing, right? So the consultant had asked them to give any damn thing to several patients. Why do you think so? The reason is, if you give any damn thing, some of the patients will get cured. There are conditions in this world, actually the vast majority of illnesses which we come across get cured with any damn thing, right? Unless it harms the patient. So likewise, one lesson to learn in psychotherapy and counseling is, if you do any damn thing in the proper manner, the patient will benefit from that. Right? The other lesson is, if you find that the patient improves in your hands, then what? Most of us would go home with the idea that, okay, because I use this psychodynamic psychotherapy or this form of counseling, that technique, or this technique, or that theory, or this concept, the patient became well. In that moment, from today onwards, learn to ask the question, whether was it the case, right? Because I will explain this to you later. If any damn thing cures many patients in medicine, in medical wards, usually seriously ill patients are admitted, what about clients who come across us? They will improve. And what consists of any damn thing? That is within our human reach and can be learned and practiced, which I will show you today. Remember that. Okay. Now, once we have learned of this any damn thing, before going to the next slide, I would like to ask a question. Let's say when your friends and relatives get to know that you are studying counseling and this, Jayawardhanapura course, some of them might volunteer to be your patients. Or out of necessity, they might come and tell you problems or whatever, ask questions. At the end of this course, what will happen? Patient කෙනෙක් ඇවිල්ලා ප්‍රශ්නයක් කිව්වම, sorry, I continue to use the term patient because I am a doctor and the relationship I have with most people are doctor-patient relationships. I don't have clients as such, but you will. Counselors, they generally use the term clients. So patient කෙනෙක් ඇවිල්ලා ප්‍රශ්නයක් අහුවම ඕ මොකක් කරේ කිව්ව යාළුවෙක් කිව්ව යාළුවෙක් කියලා හරි වැඩේනේ මට මෙහෙම වුණා කිව්ව ගම මොකද හිතන්නේ මේ වෙලාවට මොකද්ද දන්නේ ෆ්‍රොයිඩ් කියලා තියෙනවා. If your mind crosses that sort of a thought, then you need to remember this as well. What would you do if a friend is in need? If you haven't studied psychotherapy ever or counseling ever, never ever, you haven't come across any psychology textbooks, you haven't read them. Probably these are the things which we would do as human beings. Be with the friend, listen, encourage to do what is correct, appropriate, and useful. And the things like that. This is from probably a card. It says, I don't need words to express. I don't need tears to shed. I don't need to ask for a smile or a hand to hold me. All I need is to be your friend. Okay. There are things which we would do as human beings, even without studying counseling. My advice is don't lose that. From that, we come to this gentleman. His name is Carl Rogers. So he came up with this theory of person-centered approach. Person-centered approach of psychotherapy basically opposes this. Basically, primarily, consider the other person as a human being and use yourself as a human being to help others. So that is what he did. He had studied psychotherapy formally and practiced, and later found out there are things which will improve when we start treating other people as human beings. And there are fundamental assumptions which are different to Freud's in his theory. When it comes to Freudian theory, Sigmund Freud believed a very, I should say, unpleasant stuff. Death and dying, murdering, aggression, violence, sex. Sex was a very big theme for Freud. But when it comes to Rogers, what he thought was, well, human nature might be fairly positive. All of us want to do good, better human beings, do the correct things. That sort of assumptions. As a person, all of us want to develop, even a criminal or a depressed person, whoever. So he developed his theories based on those. And one of his important concepts was empathy. What is empathy? Probably you heard about this word in the morning. Empathy is not sympathy. I probably repeat these things, but empathy is defined as emotional and intellectual understanding of the other person, as if getting into other person's shoes. Not really, not exactly. We are not being drawn in to the other person's universe. We do keep a distance, but we do understand them. Yes, we should understand them. And that is one thing. Second thing, we convey that understanding to that person, so he understands we understand. And in the same line, we need to verify whether he get that point as well. So it's like the patient understands that we understand. The patient has to understand that we understand him, right? That is where empathy is. Then only he realizes that as a human being, he is listened to, he is taken seriously, he is being valued, that sort of things. So empathy is one of the most important things here. Then unconditional positive regard is probably an ideal concept, very, very idealistic one, because all of us are human beings as therapists or clinicians. So sometimes it will be really, really, really difficult for us to, even if we can empathize, it will be really, really, really difficult for us to unconditionally treat patients, especially when the patient is a perpetrator of crime against someone innocent, or a patient who is identified as a manipulator, or in such instances. So unconditional positive regard is a skill which is ideal, which we need to cultivate, develop, and practice. Right. So that sort of things. So Carl Rogers' approach to human beings was very humane. So it was called person-centered approach. There are differences between, I will come to some of these things again and again, but let's go through what I started. So I mentioned you a term called ADT, any damn thing. And any damn thing was actually scientifically studied by a few psychologists. Jeremy Frank was one. When he looked into the psychotherapy relationship, he found out some of the things work remarkably well. For example, one of the most important thing which happens in any psychotherapy is listening. And some people improve only with just listening. If therapists listen to the patient, that might do the job. So listening is one of the fundamental skills. Listen, listen, and listen, right? Then within this listening, within this, yeah. I think I'm going round and round here. Let me see. Sorry. Yeah. This is what I wanted to get to. This was the first point. It did not appear in the previous way of unfolding the lecture. First one is the therapeutic relationship. Now this is different to a friendship. This is different to a relationship between husband and wife, or mother and son, or two friends, or two colleagues.
See your slide.
Sorry?
Doctor, the screen is
Ah,
not
Are you
visible
sharing
now.
your slide? Doctor?
Yeah. Let me, sorry.
It's all right.
I think you can see now.
Yes, doctor. Thank you.
Thank you for pointing it out. Otherwise, I would have just sort of went on like that. So first one is therapeutic relationship, which is different from a friendship, as I described. So when we form a proper therapeutic relationship, the patient feel contained and patient feel confident to expose himself or herself. That is why we generally don't encourage to continue with psychotherapy or even to start if you know each other. You can't counsel friends, children, or relatives, husbands, wives, likewise, or colleagues who work with you in the same office. So therapeutic relationship is a very different kind of a relationship where the patient should come to trust you and they speak of their innermost hidden secrets. And the therapist is the one who would listen to them and keep them. So listening, as I mentioned, listening and listening is a very important part of our job. If you are not trained to listen, now you must train yourself to listen. Some people would find it difficult to listen because of their personality predisposition. These people have actually used to lecture others. If you are coming from lecturing professions, be careful. All of us are trained to teach other people or to learn from or listen. So we need to relearn some of the skills. The release of emotions. Now, listening and discussion in psychotherapy and counseling doesn't happen in a idling manner. So you don't talk with the patient about the weather today, or what happened at Aragalaya, or what happened with the cricket series. That sort of things are not discussed. Or you can, incidentally, those things might come up. But one of the most important aspect of this interview or the interaction is release of emotions. So when the emotions are released, most patients feel relieved and they improve as a result. So it's a very specific form of a discussion. There's restoration of morale. Now, almost all the time, we will listen to discussions or dialogues, let's say in radio, like in the form of cracking jokes, where someone else is ridiculed or belittled or put down or whatever. But in a therapeutic relationship, we have to use our words very, very carefully because these people have very delicate sense of self-esteem sometimes. So keeping them in good spirits, restoration of their morale is one of the most important things that we need to keep in our minds. But remember, bland reassurance or just saying positive things without any substance behind them, which appear to be, I should say, superficial, is not going to help. So restoration of morale needs to be well thought out, carefully worded kind of thing. Then providing information. There are very many instances where we come across where the patient is in trouble because he or she doesn't have adequate information. I'll give you a very good example. About 4 or 5 years back, I received a telephone call from a student, university student from a non-medical faculty. She was a non-medical student and she wanted to come and see me in person. And that was the exam period and I was busy writing something else. So I said, well, today I can't. If I am to see you, it might be in 3 days' time. So in the meantime, why don't you go to the board and talk to my registrar, who's my junior doctor? She will help you. So the patient went there and in the afternoon, she again called me. I gave the same answer. On the following morning, she again called. Now the telephone calls were increasingly frequent, right? And she was very reluctant to discuss that via the telephone. Then what happened was, due to some reason, I could not see her for about 1.5 weeks. But I made sure one of the doctors see her, did whatever which was there. And then later the doctor told me what is the story. The reason was she had had sex with her boyfriend. And it was not a vaginal kind of sex. But that made her so frightened, and she feared that she would get pregnant. And that kept her going without sleep, without eating properly, couldn't concentrate, and she was extremely anxious, right? But provision of information about how a pregnancy takes place was really what was needed for her, but she was so anxious. Ultimately what happened was she was pathologically anxious, I should say. Then later she was okay with our reassurance, but she completely got cured only when she had the menses next month. That was it. So there are instances where we need to provide information. Likewise, in the field of substance use disorders, most young men do not know that cannabis can make them go psychotic. When they get to know, they become a bit more careful. Or for example, like let's say in grief, bereavement, when somebody had died, when a loved one had died, hearing their voice or seeing them once in a while are not signs of being haunted by the spirit or the ghost. When we reassure that these things are well known even within the science, don't worry about it, that is pretty much relieving. So providing information is part of this. Providing a rationale for the reaction. Why is it happening now? Kind of a direct sequel. Like, why does somebody behaves in this manner? Is probably what is required there. So, for example, a boy cannot study because he had a relationship problem with the girl. That sort of issues. Pretty clear to us. But sometimes they might not attribute to what is going on to their behavior. If we can make the connection and provide a rationale, so much the better. That might work. Then advice and guidance. This is a very, I should say, controversial situation. Now, most teachers in counseling advise us not to advise or give any guidance as such. They boast as well. They say, oh, we don't advise. We allow the client to come up with their own answers to the problem or whatever, right? But I'll give you a concrete example where this boy who lost his girlfriend was advised by his best friend to come and drink with him. Will you advise to not to drink or not? Yes, it's our responsibility and the obligation to advise people to keep themselves away from harmful behaviors. So there is a place for advice. Then when it comes to advice and guidance, let's go back to the couch, which I put up on the second or third slide some time back. Freud is known to listen, and listen. He would not show his face. He would not talk. So he allowed the patient to lie on the couch and continue to talk. That technique is called free association. But even Sigmund Freud had to talk at some point during this therapy. What he had to do is, when there was, let's say, there was nothing much the patient could come up with, then he would have to ask a question. Isn't that so? Otherwise, the patient will not go beyond that point. Or let's say patient started crying, then he would have to say something. Now, at that point of time, even Almighty Sigmund Freud would have done something to guide the patient. Even if he hadn't advised directly, the way he talked, the intonation, or the words that he used, or the ideas that he wanted the patient to dwell in, concentrate on, would have a hint for the patient to take up a specific topic or avoid something else as well. So advice and guidance automatically happens. Don't go with the idea that we are like programmable computers where advice and guidance can be kept away by a whatever the loop or some sort of piece of software. No, cannot be done. We are human beings. We do have our own predispositions. And then when the patient takes a decision, if the patient comes to you and talk, there is always an interaction, which is colored by our predispositions as well. The skill is to learn to minimize that, but however it happens. And sometimes it is warranted. We have to advise, we have to guide. And some suggestions. Now, Jeremy Frank says, okay, these are the ADT of counseling or psychotherapy. When you do this, these were actually labeled as common factors. These happened in any relationship, any psychotherapeutic counseling relationship. Suggestions take place. Right. So a patient might improve after seeing you once or 10 times. And the reason why they would have improved was probably this, right? These are the very important things which we want you to understand and learn during the next few months. Because even if somebody is capable of doing this, that will help a lot of patients, a lot of clients. Okay, remember, once in a rare while only we will get a chance to save a life. But most of the doctors think that they are saving lives on a day-to-day basis. And the general public also believes that. It's not a bad thing for us, but it's not the case. Most illnesses recover on their own. Most patients recover on their own. Most illnesses disappear, get settled. Even COVID-19, corona, dengue, even chronic alcoholism. There is a percentage of people give up alcohol on their own without coming to us, settling without any problem, right? When you come to counseling, as well as when I came to medicine, we do have the idea that we will learn from our teachers and then go and do miracles or save lives kind of things. But generally, it automatically happens. We can control only a tiny bit of somebody else's life. So remember that. At the end of the course, hopefully you will retain the ability to be friends and smile and be human again. So psychology is a science. And then we need to discuss some of the basics of science. I know some of you all are scientists who have studied sciences, but I would like to remind few basics for the sake of completion. A science is a system of producing and using knowledge, which is based on a scientific method of inquiry. So the science which we discuss is actually Western science. We use either observational or experimental kind of methods, empirical methods, various methods. So we do not believe in certain things because that is what everyone else believes. So there might be things which we do not understand. There are things which we can't explain. That is there in psychiatry, that is there in medicine, that is there in many other fields of science. Medicine is common. Most of the time, we don't know why did the patient improve. Nevertheless, we give medicine. Right? For example, fever and paracetamol. We still don't know the exact mechanism of action of paracetamol. But that does not mean that it is unscientific. The science behind using paracetamol for fever is we have given paracetamol for 100 patients and probably 90 patients have shown improvement. So that is science, or that is the level of science. But we don't know the exact mechanism. How does it work? So there are so many things. When it comes to scientific theory, there are certain characteristics. One is it could be disproved in the future, hopefully, or even now. Some of the theories which we are using now are already known to be false, but nevertheless we talk of those. One is the theory of gravity. අපි හිතන් ඉන්නවනේ මේ ගුරුත්වාකර්ෂණය කියලා එකක් තියෙනවා කියලා. මේක නෑ මේ ලෝකේ. So it was disproved on the very first day it was discovered because Newton could not explain the motion of the Mercury around the sun or things like that. Anyway, so one of the most important characteristic of a scientific theory is it is falsifiable. විද්‍යාවේ තියෙන මේ ලාක්ෂණික ස්වභාවය තමයි මොකක් හරි ඇත්ත කියලා ඔප්පු කරන එක නෙමෙයි. යමක් බොරුයි කියලා ඔප්පු කරන්න පුළුවන් වෙන එක. අපිට ඒක පේන්නේ. Now why I am talking about these things? Because if you take some of the Freudian theories, this is difficult, right? Then we use hypothetical deductive method. That means we come up with a hypothesis, then we prove that, or we disprove the reverse of it, null hypothesis. We come up with the assumption that reverse of that works, and then we disprove it. So we assume that the other theory should hold true. That sort of things are there in science. However, when you look into psychology, theories of psychology, these were not the theories which we used in scientific psychology as well. For example, now Freudian theories are still in use. We still use them and they are useful. But Freud came up with the theory that in very young people, they have this libidinal or sexual attachment to their mother. They derive sexual pleasure by sucking the mother's breast. So it's labeled as the oral phase. Oral means the mouth. Oral phase. And primarily, the pleasure center is the mouth, where you would derive pleasure by sucking and tasting and various other things. Now, there is no way of proving that. But the problem is no way of not proving that, but problem is there is no way of falsifying that. Now, can we ask from a child of 2 months of age? No, there is no way. So from a strictly scientific point of view, what Freud was talking was more or less what? Fairy tales. Not really scientific as such, but it's like paracetamol. If you use Freudian theories to treat patients, and if you treat 100 patients, if more than 50 improves, then you will say, well, when we use this theory, we show some response to the intervention. Then that is science, that is scientific. At least that has to be there. Then on the other hand, when you study developmental psychology, you will come across a person called Jean Piaget. teachers would know him. Piaget actually came up with the cognitive development theory of children, where he described that children develop in their cognitive abilities, their ability to think, reason, and various other things in stepwise manner. How did he do that? He did not take 100 children and measure their cognitive. No, he wasn't doing that. How did he do it? What he did was, he just observed how did his 3 children grow up. Was it science? Well, yes. What about the numbers? No, there were no numbers. What about the hypothesis? There was no hypothesis as such. What he did was, he observed very carefully what was actually happening. These actually belong to qualitative methods of synthesis science, qualitative sciences. There are no statistics. So why I'm telling you these things, as clinicians, we need to develop that capacity to observe phenomena, psychic phenomena in patients, and then identify changes. So even a single patient or a client might teach you a lot. Who knows? One fine day, one of you might come up with a different theory. That's great, then we can be happy of that. But this is how some of the scientific things in psychology progressed. There were no hard sciences such as physics or biochemistry, where people took samples and did very meticulously accurate measurements and then use those findings to disprove hypotheses. So it wasn't the case. But people observed how humans behaved, thought, and communicated, and developed, and then came up with various theories which helped us to deal with misery. So that's what. The other one is Darwin. He was not a psychologist, he was a natural scientist. Darwin was a medical doctor, by the way. The Beagle, the ship he was doing the job of medicine man, carried him to various places, including Galapagos Islands. There he observed subtle changes in the same species of animals and birds. And then he realized that due to geographical separation a long time ago, these subtle adaptations have taken place. So he came up with the theory of natural selection. And in combination with genetic mutations theory, then we ended up having the theory of evolution. These were actually, Darwin's theory was a qualitative observation. Mendel's observation was, of course, a quantitative one. And Karl Marx, not a psychologist, but political theorist. He observed what happened. He read about how do the other civilizations do, and found out this is how economic transactions take place, the political systems evolve, that sort of thing. And that is science now. Okay, I will come to this in a few minutes time. I'll give you a small break, 5 minutes. Okay. Okay, I'm going to start again. Can you all hear me?
Yes, sir.
Right.
Yes, doctor. Yes,
Yeah.
doctor.
Yes, sir. Yes, sir.
So,
Yes, doctor.
hi. So we'll start with this. Freud has written a book called Interpretation of Dreams. So what he has done was actually went through the
Excuse me,
case.
doctor, can you see the slides again?
Let me.
Yeah.
Okay. Yeah, hope you can see it now.
Yeah, now we can see.
Yeah.
Okay, thanks.
So what Freud did actually was, as I told you earlier, he had this clientele of young, wealthy women coming from his Western European country, Austria, Vienna, that area, and they were talking about the various things that happened to them in the past as children. Most of them talked about sexual themes and how they were molested or abused or some of these things. So gradually it allowed Freud to come up with this libido theory where he assumed that sexuality was the single most important driving force in our lives. And then later he came up with the rest. While doing that, he realized that some of these people come up with dreams, actual dreams. And when a patient recalls a dream, Freud went in to analyze the dream. He called it interpretation of dreams, because he actually taught as dreams are the royal road to unconscious mind. So his belief was that the things which are there in our unconscious mind are expressed in dreams. So in a manner which is acceptable to us. So in dreams, for example, we might replace one figure with another. Like if we see somebody killing us or trying to kill us, it might not be the actual person who tried to harm or harmed us in real life. It will be maybe similar, but a different person, because that is less threat. Then there will be several themes amalgamated together, expressed as a dream. And wish fulfillment. Some of the things which we can't have in our real life, we wish for, are fulfilled in our dreams, in our fantasies. So likewise, he interpreted what has happened to us in the past, dictate our dreams and control what we feel, think, and behave. So that was his main assumption and theory, which is still being used as a theory in psychodynamics. There are psychotherapists who analyze dreams. So that is how it was. But what is the situation when it comes to our part? The Freudian assumption is the past affect us. He lived in this post-Newtonian world where mechanics played a major role in our thinking. So there was always a linear flow of time from past to present and to the future. Likewise, when there is a cause-effect relationship, always the cause preceded the effect. So in his world, or his interpretation, past affected us. So in a dream, there are manifest content. So we see something we dream of. Let's say we dream of flowers. That might be the manifest content. But the deeper meaning of that latent content might be something different. Like he usually says something sexual. want to have a sexual relationship, that particular person who was with the flowers or what, right? And condensation is where several themes are together. And as I mentioned, you wish fulfillment. අපිට සාමාන්‍ය ජීවිතේ දකින්න හිතන්න ලබා ගන්න බැරි දේවල් අපි හීන ලෝකේ දකින්න, which is common sense, isn't that so? Right? Any person would like to have at least certain things dreamt of. So that was his, but at the same time, one of his theories was that infantile sexual drives was also attached to these dreams. Now these dreams are related to our personality development, always. And as a person, any one of us do have this sexual drive, a flow of energy in relation to unconscious mind. So these things are related to each other. And past trauma, the things which happen to us as children at a very young age, affect us, will continue to affect us till we die. And he didn't tell us what happens after we die, but these trauma affect us in a not so pleasant manner most of the time, right? So these are the concepts that he came up with. So one of his greatest idea was Oedipal complex. This is a Greek mythology. Oedipus was son of, I can't remember his father's name, a Greek king. And when he was born, it was predicted that he would kill his father and get hold of the throne. So he was, somehow he was sent away out of the country. And later he was raised in another location, became a young man, young, fit, healthy, very capable person, and due to some reason, he had to leave that place as well. So whilst he was coming to his birthplace, without knowing that he was born there, without knowing that his father was a king, he went through a very difficult, poorly developed road. And on a bridge, he met this older person in a carriage. And then due to something, they had an argument and then a fight. And Oedipus killed the old man. And then he came to the city. When he came to the city, later he got to know that he had killed the king. And then he became the king himself and he married the queen. And later he found out that he had actually killed his father and married his mother and had an intimate relationship with his mother. Because of that, he blinded himself by injuring his own eyes. This is what the picture depicts. That is the story. So Freud actually incorporated that idea to his theory of sexual development. In some point of time between the ages of 3 and 6, both male and female children have an attachment towards their opposite sex parent. අවුරුදු 3-6 අතර ළමයි තමන්ගේ විරුද්ධ ලිංගික දෙමව්පියන්ට තියෙන ඇල්ම වැඩි වෙනවා. තාත්තට දුවලා අම්මට පුතාලා වගේ. And he described it using this story. What he said was, in that developmental phase, children do have a sexual attraction towards the opposite sex parent, but at the same time, since their cognitive maturity, their understanding improves, they realize that they are actually competing with their mother or father for that love. And that's pretty threatening, because these are the very people who protect them, feed them, care for them, look after them. And they are very authoritative figures. So that creates a very difficult situation, an extreme anxiety, which Freud labeled as castration anxiety. Because castration is what? Removal of testicles of a man. So these sort of these are actually now there is no difference between Greek mythology and Freudian theory, isn't that so? He just extended the story of this complex Electra and what did I told you just now? Who is here in this picture?
Oedipus.
Yes, Oedipus complex. So it is as if what happened to Oedipus was extended in his theories in order to explain so what happens psychologically. Okay, there is no way of proving this scientifically. That is why I was discussing the theory of science in psychology, but we do use these sort of things in our practice as well, but at a different level. So what happens is when a child grows up at this Oedipal developmental phase, he or she has to resolve this complex, resolve this conflict in the mind. Now this boy loves his mother, but he knows that the father is a very powerful person, and he fears that because of this love, if he is competing with his father, and if the father identifies or recognizes this, discovers this, he might kill. And even going beyond killing, the child apparently gets the fear of being castrated. His testicles would be removed, so there will be no actual sexual capability left with him. So that is what Freud thought and he wrote about. So these sort of things are manifested in this unconscious mind. Let me go back. Where did I? Excuse me. Yeah, so we were at this interpretation of dreams, and that is what Freud told. So when it comes to dreams, these sort of conflicts might get manifested in a different manner. So that is what. So he came up with the theories of unconscious mind. And he realized that when we grow up, these libido or sexual drives and
Excuse me, doctor, you have stopped sharing again.
thank you. Let me see. Yeah, the next slide. Okay. So this is the one which I started with. Yeah, Freud came up with this theory of id, ego, and superego, where he described the function of the mind using different aspects of it. Basically, what he realized when he listened to these patients was these animal kind of desires of violence, aggression, and sex do not get manifested because there is some control and some balance taking place inside our minds. It happens because we are social beings and we learn certain things, and that aspect of the mind was labeled as a superego. And the animal kind of our mind, where we want to gratify our wishes, desires immediately, was labeled as id. If we want to have food when we are hungry, we want to eat somehow, but we will not be stealing food because there is a learned aspect of our mind, which is called the superego, which we acquire by social development, which controls id, and the balance is maintained by the ego. Right? This is one way of structuring the mind. And when it comes to development, as I mentioned earlier, Freud thought our development takes place in several stages. First one, as I mentioned earlier, the oral stage, where the young child will derive some pleasure through his or her mouth. That was called the oral phase, where the sexual gratification was acquired through mouth. Then later, from 1.5 years to 3 years, it was the anal phase, where they were preoccupied with defecation, excretion. at this age, children generally play with their own excreta, stools and waste. They want to experiment and see. Yeah. And they gain control over certain functions like bladder and bowel functions. They can delay somehow. And then the third one is the phallic stage of development. Phallic stage is where they develop the difference between male and female differentiation, and then they start attaching themselves towards the opposite sex parent. And at the same time, in order to resolve the conflict which develops within their mind, they take up the activities of the same sex parent and treat the opposite sex parent at the way that their same sex parent treats. And that sort of sexual development stages were described, and Freud stopped at that. There are other theories which describe beyond that, Erickson's theory. So when it comes to what happens to us, was described as developmental arrests, like, from oral to anal phase or anal to phallic phase or whatever, or in one of these phases, there might be some trauma taking place. Trauma is some insult to our mind, actually. The oral phase can actually sustain trauma. For example, let's say there is a very young child whose mother dies while she is breastfeeding, or leave to, let's say, Middle East, or even a temporary separation due to an illness, or not a separation, but they get another child. Any insult, any injury, any stress can act as a trauma. It's a very individual thing, and there is no way of scientifically finding out what it was. That looks very unscientific, isn't that so? Freud is considered one of the giants in psychology, psychotherapy, and even psychiatry. But most of his theories are, well, stories. Like, we don't know, we can't prove. How can you prove? That is where they are. But we use this theory, we use this model to explain certain stuff as well as treat conditions. Anyway, due to this trauma, there is an arrest of development in this oral phase. For example, mother being separated, there will be trauma in the oral phase, and then arrest of development usually lead to depression kind of illnesses. That is what we know. So what did Freud come up with as a treatment? Was not medicines. What he told was, okay, if we go back, if we found out what actually has happened in the very distant past, whilst knowing that we can't do that, he himself knew that you can't explore a child to, near, let's say, even beyond 5 years, most of us can't remember, right? By the time we reach adolescence and early adulthood, what happened in the very first year, the second, third, or the fourth year will not be remembered as such. But actual techniques are very different. But the theory is, when we go back and allow the patient to come up with the whole story, tell it, identify it, come to terms with that, and understand that is what actually has happened to him or her, there is a reparation takes place. So that is what the treatment is based on. And then there will be relabeling of what has happened, and hopefully re-traumatizing or healing. Sorry, I made a mistake there. So this actually happens culturally in the Western. These are two concepts. Sorry, I should separate it. Labeling of what happens to us. For example, now if you read textbooks on treatment using these sort of models, one of the most important aspect of our involvement with the patient is to educate him of what we are going to do. As counselors also, you must say, I'm not going to give you medicine, but this is how the counseling will unfold. You will have to come for these sort of sessions, and you will have to tell me the truth, blah, 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 kind of, and this is how the healing takes place. So this model needs to be learned by the patient to come out of the condition. And what has happened now is the whole of the Western civilization has learned it. Everyone, you read books, you find this sort of thing. You watch films, still they are there, even in cartoons and what, right? People talk about these things. It's there in their minds, right? And some patients directly come and ask, doctor, can you do this sort of a therapy so I can get rid of my childhood trauma? Trauma equals damage equals dysfunction. Kind of a theory is there in our minds, who has to be there in order to, one, to be ill and to be treated. So there are a few things. One is this relabeling of what has happened to us. And then re-traumatization. This is a different topic which I deliberately put it here because I want you all to be conscious of this. Now, enough and more instances I have come across, let's say women, young women coming for treatment of some other thing, right? And later, one of the doctors, or sometimes they themselves, go a little bit deeper into their history and find out that there is a sexual trauma, some sort of molesting, touching, let's say not rape as such, but some indecent activity happened in her life some time back. That sort of things could have taken place because without knowing that would have been there. But if you look at her life, she had lived a productive life, done whatever which was requested from her to do, was responsible, this and that and everything, but suddenly this event happened and it was difficult for her to tolerate, and that's why this happened. So some biological problem occurred and it triggered a depression or whatever, right? Now remember, if we find out such an instance in the patient's life, you can do two things. One is just leave it as it was. Don't dig, don't re-traumatize, because sometimes trauma takes place at the time of the exploration. Again, මෙන්න මෙහෙම එකක්. අවුරුදු 6 දී විතර තමන්ගේ ගෙදර හිටිය වැඩි හිටි කාගෙන් හරි හෝ අල්ලපු ගෙදර කෙනෙක්ගෙන් හෝ ලිංගික අපචාරයට වගේ ලක් වුණා වගේ කතන්දරයක් අපිට අහන්න ලැබෙන අවස්ථා තියෙනවා. හැබැයි මේ කාන්තාව දැන් වැඩි හිටි වයසට ඇවිල්ලා යහතින් ජීවත් වෙනවා කිසි කරදරයක් නැතුව. අපිට ඕක අහුව වෙලාවේ අපේ ආකල්පයේ තියෙන අනේ පව් ඔයාට මේමත් උනාද, ඒකනේ මේ sexual abuse වලින් කොච්චර කරදර වෙනවද, ඊට පස්සේ මොකද උනේ, ඔයාට නිින්ද යන්නේ නැතුව තිබුණාද, අරකද මේකද කියලා හාරගෙන අවශ්‍යගෙන ගියොත් මොකද වෙන්නේ? මෙච්චර කාල දැන් එයා මේක, she has come to terms with this, she has contained this, ප්‍රශ්නයක් නැතුව මේකට අනුගත වෙලා තිබ්බ ජීවිතේ අපි ට්‍රෝමටයිස් කරනවා මෙතනට ඇවිල්ලා, රීට්‍රෝමටයිස්. ඒකට කවුන්සලර්ස්ලා විදිහට මතක තියාගන්න ඕන දෙයක් තමයි මේ හොඳින් ඉන්න දේවල් වාත කරන්න හදන්න එපා. Don't re-traumatize and make people pathological. So remember, there are enough and more men and women out there who were abused as children. But that does not mean they had to be taken for therapy and made to talk about what happened to them and explode. No. That is not the case, right? If the patient has come to terms with that, somehow labeled in a different manner, we should not explore it, dig it out, and then relabel it as a trauma and traumatize at that point of time. Since we believe in Freudian theories, this actually can happen, because Freudian therapists believe that unless you clear everything, the whole life, and reorganize the thinking pattern, nothing will change somehow. But that is not the case. We can still leave things as they were without touching them. I give you the example of let's say somebody hammering a nail to a tree trunk. ගහකට ඇණයක් ගැහුවම මොකද වෙන්නේ? අඹ ගහකට ඇණයක් ගැහුවා කියන්නේ අඹ කිරි බේරෙනවා. ඇණේ ඇතුළට වැදුනම we don't know whether the tree feels any pain, but we do see the reaction. Some sap will come out and there will be evidence of trauma around that. ඊට පස්සේ ටික දවසක් ගියාට පස්සේ මොකද වෙන්නේ? ටික දවසක් ගියාට පස්සේ ගහ මැරෙන්නේ නැහැ සාමාන්‍යයෙන්. මේ ඇනේ වටේට පොඩ්ඩක් ඉදිමෙන්නා වගේ. Then after few months, then probably you will see that the tree nonetheless grows, whether the nail is there or not. And after few years, there might be a scarring there. There might be some sort of evidence of some trauma happened, but nothing more. Now the tree has grown so big and the tree bark has grown around the nail, obliterating it, concealing it, and a casual observer might not see it. And the tree is also not troubled by that. මේ ගහේ ගහපු ඇනේ දැන් ගහටම එකතු වෙලා ඉවරයි. ඒකේ කරදරයක් නැහැ. ඇති අපිට කියන්න බෑ. හැබැයි මේ ගහේ ඇණයක් තියෙන ඔය ඇනේ හොඳ නැහැ ඔහොම තියෙන එක අපි ගලවන්න ඕනේ කියලා අපි ආයි හාරලා ගැලෙවොත් මොකද? Then you will be creating more problem there. So that is one thing you need to remember as psychotherapists and counselors. Along with that, I am going to tell you a little bit more about Freudian theories. Now, Freud, in his dream interpretation, describes certain things. One of his theories was the past trauma can be manifested in dreams, and there will be wish fulfillment and various other things, and everything to do with the past usually. මේ චිත්‍රය ඔයගොල්ලෝ අඳුර ගන්නවද? Can you identify what it is? Oh, Mahamaya Dutu Sihine. And this is the dream interpretation in the Eastern tradition. Does this picture or the drawing of Mahamaya and her dream talk about the past or the future? මේක මේ අනාගතය ගැන කියන්නේ ඉස්සරහට වෙන දේවල්. If you look into the dream analysis in the East, primary focus is on the future, not the past. පොඩි කාලේ ඔය ආච්චිලා එහෙම කියන්නේ හේරලි දැක්කොත් තියෙන්නේ මොකද වෙන්නේ? පෙරලි වෙනවා. පෙරලි කියන්නේ කොස් පැහිච්ච. පෙරලි දන්නේ නැති අය ඉන්නවද දන්නේ? පෙරලි දැක්කොත් පෙරලි වෙනවා. දතක් ගලවන දැක්කොත් සහෝදරයෙකුට කරදරයක් වෙනවා. Likewise, there is a list of commonly associated beliefs around dreams in our culture as well, even in Sri Lankan culture. Right? So Mahamaya Dutu Hine and Siddhartha Bodhisattva's dream about worms infesting up to his knee joint, that sort of things. And 4 birds coming from 4 corners of the land and falling at his feet, that sort of things, right? Those are about the future. There might be similar dreams in Mahabharata and Ramayana, that sort of things, right? So the dreams in our culture were interpreted in a very different manner. Chronologically, probably the antithesis, so quite the opposite of what Freud thought. And we are dealing with Sri Lankan public, remember. Our people are different. Unless you have already taught the Freudian theory of psychological trauma giving rise to symptoms nowadays, they might not believe in such. And we need not believe in such as well, right? Mahamaya Dutu Sihine සත්‍ය අසත්‍යතාවය විද්‍යාත්මක ඔප්පු කරන්න බෑ වගේම ෆ්‍රොයිඩ්ගේ එකක් බෑ. Nevertheless, we use, right? Somehow we use those things, and at a certain level, they have been shown to be useful in treatment. Anyway, I've just illustrated to you that you are practicing counseling in our context, then you need to know about what's happening here, what our people believe, and need not one other example I remember very well, pretty well from my childhood reading. Alexander Dumas, one of the best French writers. There was a small book called Corsican Brothers where there is a dream he describes. This young man dreams of his father coming and telling him this is what is going to happen. And the same thing happens on the following day. Either he kills the rival or his brother gets killed. Those two things. Likewise, there are other dreams. Right. So, yeah. Basically, the dreams foretell the future here. Okay, that's about dreams. තේරුණාද ඔයගලන්ට ඒක? මේක මම දැම්මේ කියන්න අපි වැඩ කරන සංස්කෘතිය වෙනස් විද්‍යාවේ සිද්ධාන්ත මොක වුණත් අපිට ඒකත් දැනගෙන යන්න ඕන කියන එක. Counseling is a human affair. So we need to have some understanding of with whom are we working. If you have read the classics, let's say the Jataka stories, Mahabharata, Ramayana, that sort of things might be of use sometimes. Okay, from that we come to another psychological theory which can be used in counseling very effectively.
Dr. Jayamal,
Yeah.
I have a small question to ask. Is that okay?
Yes, you can ask.
Yeah. Now, this question is based on those dreams. As you said, now that dreams cannot be proven. So now, as you said, the psychology is a science. And then when those dreams cannot be proven and when there is no scientific foundation and background, so won't there be a conflict between certain concepts and practices based on that? I have a small...
There are. For example, now some of the modern theories do not believe in Freudian psychotherapy. They say
okay.
some people say that's useless, right? You can do without that.
Okay.
So it's well known. There are people who wouldn't mind leaving out these theories. On the other hand, there are psychotherapists who are inclined to use these theories, and what they say is, okay, let's forget about proving whether this sort of a theory is correct or not. But if you apply this to, let's say, 100 people, let's look whether 50% of them improve, that sort of thing, right?
Okay.
So the original theory might not be proven, but the application might be beneficial. Paracetamol වල කතාව මං කිව්වේ ඒකනේ. We don't know how does paracetamol works. We don't know the exact molecular mechanism. But we know when you give paracetamol to 100 people, it brings down fever. So in that sense, it is scientific. Scientific in the sense, not as, yeah.
Okay. Now I understand. Thank you very much.
Yeah. So then we come to some of the other sciences. This is from behavioral science, behavior theories of psychology. Make දැකලා තියෙනවද ඔයගොල්ලෝ? How have you heard of Pavlov's dogs? Ivan Pavlov was a scientist who was experimenting. He was a physiologist experimenting with gastric secretions of dogs and other animals. He was not a psychologist. So he had dogs in his laboratory who were subjected to experiments, and he had these various tubes inserted to their abdomen, to the stomach, and taken out to measure how much of acid is secreted, that sort of things. Then he realized that towards the time when the dogs are fed, they start salivating. බල්ලොන්ට කෑම දෙන වෙලාව ලඟ වුණාම මේ ඉවාන් පාව්ලෝගේ එක්ස්පෙරිමන්ට් එකේ උන්ට කෙල එන්න ගන්නවා. He could not explain it very well because he was sure that the dogs could not smell food. So he thought what was going on. Then he realized that the lab assistant who used to feed these dogs was either washing these plates or doing something with them which emanates some sound, noise, this clickety clackety kind of metallic noise. And given the fact that the dogs have a very sharp and much more sharper sense of hearing than human beings, they hear it and then they start salivating. But this does not happen with the newer dogs which are adept. Only dogs who were there for a few days or more. So how did that happen? Then he realized dogs learn that their food is being brought at that time in these sort of plates. Even they don't touch food, smell it or taste it, when they hear the noise, they have learned it. That's called associative learning or classical conditioning. These sort of theories are also very useful in some forms of counseling and psychotherapy. I will give you an example. Let's say this young child, 4 years old, is being taken to a supermarket. Then she sees her favorite type of lollipop or toffee or chocolate or whatever on a shelf. And what will she do? දැන් සුපර්මාකට් එකට උන්නේ ළඟ කඩේකට ගියත් ඇති ටිපි ටිප්ප නම නම් එල්ලලා තියෙන පේන ළමයින්ට. So she will start crying, howling. She will fall down, put up all 4 limbs and throw a what we call temper tantrum. Now with this young mother who took her to the shop, being embarrassed, what will be the response of the mother? තාම මොකද කරන්නේ? මට හරි ලැජ්ජයි. දැන් බබා බිම පෙරි පෙරලි නටනවා මට අර ටොෆි අරන් දෙන්න කියලා. Which is not very costly as well. But she knows that if she continues to give these sort of sweets, the child will have problems, decaying teeth and various other things. But there is no choice. Other people are watching. Mother is embarrassed and the mother will buy whatever the child is asking for. Now what happens? How will you describe this using behavioral theories? And if you are to handle this, what will you do? So this is a situation where we can understand using behavior. There is no psychodynamics. මේක මේ යටි හිතක් ගැන උඩු හිතක් ගැන කතාවක් නැහැ. මෙතන කෙලින්ම මේ පැහැදිලි පේන්න තියෙන අපිට තේරෙන හැසිරීම රටාව තියෙන. So we call it a behavior. So in this behavior, what happened to the child? She sees the toffee and she asks from the mother. Mother says no. Then she starts crying and again no. Then she starts howling again no, and she starts dropping on the floor and put limbs up and put a full-blown temper tantrum. Then she gets a toffee. So that is what is happening. For the baby, for the child, if you see what I have written as the topic, ABC, antecedent, behavior and consequences. These 3 letters stands for antecedents, consequences and behavior. So antecedent for the child is seeing the toffee, the desire to take it, or the mother had bought it previously. And the behavior is escalating her behavior up to a temper tantrum. Temper tantrum කියන අර පොඩි උන් අතපය හතර වන්නලා කෑ ගහලා බිම වැටලා අඬන එක. අන්න ඒක. When she does that only she gets the toffee. Consequences is she will get that. Now in this scenario, if we take her behavior, what will happen with the second visit to the same shop? Will she do the same thing or not? Yes, because then only she will get it off. And how has she reached that level? She has learned it. She asked for it, probably wasn't given. She had cried, then it was given on the very first day. Second day she had tried, but no. When she started howling and fighting for it, then she was given. So this was a behavior which was reinforced. This is a different kind of a theory. Then what happens to the mother? Now, On the first day, mother takes the child to the shop. She starts crying. She buys a toffee and crying stops. So the mother feels relieved because the child stops crying. So antecedent of the mother's behavior is child crying. Consequence of the mother's behavior is her feeling relieved because the child stops crying. And her behavior is buying a toffee for the child. If we want to change this behavior, you have to either change the antecedent or the consequence. If we try to change the antecedent, let's negotiate with the child. Ada aran denna toffee. Mokada ee aran dunne. Ai heta thamai. Then that changes the expectation and the child will not cry. Right? Or you change the behavior consequence. Child will throw a temper tantrum. You just wait and see whether child calms down. And usually, unless the child is pathological or having a major psychiatric problem, they calm down. And you need not do more than that. On the second day also, she will learn, so that is a behavioral analysis of the situation where we can use this theory to help the child. Okay, there are other things in counseling which we might use coming from psychology. One is the meaning of life. දැන් ඔයගොල්ලෝ මොකටද මේ counseling කරන්න ආවේ? Since I can't see all, I can't pinpoint to somebody and ask. I wish I was doing this face to face. So you can ask the same question from me. Why am I teaching now? But let's say this is my job. So any of our acts are related to the meaning of life as we create it. This is Viktor Frankl. He was a Viennese psychiatrist. He was trained in medicine, and after that he was trained in psychiatry. He was a psychiatrist in Austria, Vienna, at the time when the Second World War erupted. So he was taken as a prisoner of war, and when the Germans realized that he was a doctor, he was not killed. But before them identifying him as a doctor, he had horrible experiences. One day the Germans will come and ask them to be in a queue, and they will shoot every other patient, the man in the queue, right? And Viktor Frankl was saved. Likewise, several instances of killing took place, but he was not killed. His wife was separated from him and was put in a different camp because there were only men in this, mostly. And later he was transferred from one camp to the other, and at last to the Auschwitz camp, where so many people were killed and burnt. And so many atrocities took place, including unethical medical experiments. People were subjected to X-rays just to verify medical theories. So what happened was, when he was known to be a doctor, he was spared at times, and he was asked to treat other prisoners as well as guards and the soldiers. Somehow he survived. And once he came out, once the war ended, he migrated to USA and started practicing. And then he came up with this theory of logotherapy, where he actually took the theory of the meaning of life as the central theory in his delivery of treatment therapy. And he wrote this book. This is available. There is a Sinhala translation as well. Leelananda Gamachi or somebody translated it to Sinhala. English one is very accessible. You can read and learn. What he says there is, now, as long as we have some hope, some meaning in life, we would continue to hold on. We will not kill ourselves. We will be hopeful. We will live. And when he observed how prisoners of war died, not killed, or sometimes getting killed, the first thing he noticed was they give up. They give up their hopes. And that is how the whole process starts. And within few days, they die. So meaning of life is very useful when it comes to counseling, because some of us need to be reminded of it at times. Why are we doing this? Why are we behaving like this? How does it relate to my overall ambition in life? Why do I exist? Kind of questions. One thing, sometimes we as therapists will have to ask. Sometimes the patients themselves experience or face this, and they themselves come up with, because they want to resolve this. It's important. So there was another thing he mentioned, that is, there is a gap between the stimulus and the response. That means if something happens to us, there is always a small time or space or a gap where we can take a decision and act if we want to change our lives. And that is how successful people or happy people or so-called normal people live, rather than being impulsive and acting on our whims. So allowing the patient to discover the ultimate meaning of life helps people to come to terms with the current adversities that they are facing. These theories actually come from existential theory of philosophy. Existential theory is existence, the being, who we are and what is the meaning of everything, that sort of things. සාන්දෘෂ්ටිකවාදය කියලා අපි සිංහලෙන් කියනවා. ජීවත් වෙන්නේ ඇයි වගේ දේවල්. John Paul Sartre kind of philosophers initially came up with these theories, and then later they were used by psychologists to come up with different kind of psychotherapies. So this is something which you can read and learn, right? Then there are other theories. Now I told you about the pure behavioral theory. Now behavioral theory is just about behavior. හැසිරීම ගැන විතරයි. ඒකේ අපි හිතන හැටි හිතන්න. I gave you the example of that little child. පොඩි ළමයා ටොෆී ඉල්ලලා අඳනකොට ඒක නවත්තන්න ක්‍රම දෙකක් තියෙනවා කියලා මම පෙන්වන්නේ. එකක් තමයි ඇන්ටිසිඩන්ට්. ඒ කියන්නේ එයා බලාපොරොත්තු වෙන දේ වෙනස් කරන එක. එක්කෝ ඒ කඩේට යන්න නැතුව ඉන්න එක, වෙන කඩේකට යන්න. එහෙම නැත්නම් consequences. එයා මොනවා කරත් ඒක දෙන්නේ නැහැ. එතකොට එයා ඉගෙන ගන්නවා ඒක වෙන්නේ නැහැ කියලා. But we don't know what happens inside the mind of the child. And we are not bothered. We did not think that it is relevant. What we were concerned with was the change of the behavior. If that happens, that's quite all right. Right? There is no need of worrying about it that much. Our theories might not hold true even. අපි හිතන එක නෙමෙයි වෙන්න පුළුවන් වෙලා තියෙන්නේ. But later, in 1960s, this person, Aaron Beck, and even before that, there was another psychologist called Ellis. They were concerned about the thinking pattern as well. Now, a remarkable thing happened. By the time the Second World War finished, there were newer discoveries in psychiatry. One was called Largactil. That was a trade name. Actually, it's chlorpromazine, which was a tranquilizing medication. It was used in war. Especially now in the Second World War, there were medical doctors treating the soldiers who got ill. And there was this condition called shell shock. Shell shock is මොකක්ද? ලොකු බයක් වෙන එක හිතට. And then the soldiers started behaving in a very abnormal manner. That was one thing. Second thing, there was psychosis. ඔබලා ඉස්සරහට ඉගෙන ගන්නේ බින්නෝන් මාදේ කියලා ලෙඩක් තියෙනවා. Schizophrenia. Schizophrenia is a mental illness where people's ability to test reality disappears. They would not identify the difference between words or the voices actually heard and the imagined voices. And then they will respond to imaginations in the same manner that they would respond to the real world phenomena. So these sort of things, psychotic situations also arise. So once this chlorpromazine was discovered as a sleeping medication that tranquilizes, it was a tranquilizer medicine. It was applied by military doctors to soldiers. And when they were given these injections of chlorpromazine, later they found out unexpectedly, even the psychotic symptoms disappear. There is a cure. So up to that level, there was a major problem in psychiatry, which used psychoanalysis, the Freudian therapies, as the mainstay of treatment. Psychiatrists have realized that whatever they do, however much they analyze, there is a group of people who don't improve. They worsen actually. So what happened was the medical treatment for psychiatric conditions were discovered, and the place for psychoanalysis gradually diminished. And then the behavioral themes also came up. Behavioral therapy was proven to be effective in certain instances, such as phobias, obsessive compulsive disorders. All these things you will learn later. However, this old school psychoanalytic training was there. So by the time Aaron T. Beck was a trainee in psychiatry, they themselves had to undergo psychoanalysis. අපිටත් එහෙම කරලා තමයි ඔයගොල්ලන්ව ගන්න තිබ්බේ පොඩ්ඩක්. ඇනලයිස් කරලා බලලා ඔළුවේ මොනවද තියෙන්නේ කියලා. කවුන්සලින් කරන්න හරියනවද මේ පර්සනැලිටි එක නැද්ද කියලා. There is no way of deciding using an exam or a viva or a interview or a CV. or හරි නැති අය එන්න ඉඩ තියෙනවා. So likewise, in the past, people thought, of course, we will analyze all the students who come to do psychiatry. And that is what happened. So Aaron T. Beck underwent what they call self-analysis as a student. And then he had learned these behavioral theories as well, and about the emotions and feelings. Later, when he started practicing psychotherapy as well as psychiatry, when he looked around, he thought to himself, well, I have so many colleagues who have undergone analysis, but I don't see any change in their personality. They have not become better people. දැන් අපි theoretically අපිට පේන්න ඕනේ මම හොඳ වෙලා ඉන්න එපා මිනිස්සු වශයෙන් psychoanalysis කරාට පස්සේ. එහෙම එකක් නැහැ. So Beck was a bit pessimistic about psychoanalysis. At the same time, he had the luxury of learning the behavioral therapies, which have progressed a lot. මේ phobias වලට, බයවල් වලට එහෙම treat කරලා behavioral therapies ගොඩක් improve වෙලා තියෙනවා. And then he realized that if you successfully treat somebody using behavior therapy, their cognitions also automatically change. අපි හිතමුකෝ පූසන්ට බය ළමෙක් ඉන්න. පූසන්ට බයයි. එයාගේ බය අරින්න පුළුවන් ලේසිම විදිය තමයි පූසන්ට යාව නිරාවරණය කරන එක. ගිහලා ළඟින් තියනවා, අල්ලන්න දෙනවා, ඕමම කරලා ඒ කියන්නේ මුලදී පින්තූරයක් බලන්න දීලා එහෙම gradually expose කරාට පස්සේ බය නැති වෙලාම යනවා. ඊට පස්සේ යාගෙන් අහුවොත් පූස ගැන මොකද හිතන්නේ? Then she will tell positive things, right? එතකොට automatically the thoughts has also changed. Thoughts have changed. So Beck came with the idea that feelings, thoughts and the behavior are interconnected in a triangular manner, and if you change one, the other two are bound to change. So he came with the concept of cognitive therapy. That means a treatment mode to change the thinking pattern, not only the behavior. As a result, of course, the behavior also changes. And he found out it can be administered within a shorter period of time compared to psychoanalysis, which takes a huge amount of energy and time, both patients and the therapist. But this can be done in a faster manner. But not all the problems are amenable to cognitive therapy. However, he started doing that. So that is how we ended up having a term called cognitive behavior therapy, where we would identify the patient's thinking pattern and try to do something about it in the form of challenging thoughts, substituting them with alternative patterns of thinking, kind of things. You will learn the basics of those later. But in this introduction, these sort of things are there. So just a brief introduction to Beck's theory. He says all of us have core beliefs about this world, ourselves, our lives, future, and all, right? And we do have assumptions as well. Some of us have negative assumptions. And in certain situations, we have coped fairly because we have managed the situation well. But there might be situations which are threatening to us. And these threatening situations will trigger automatic negative thoughts and images and will give rise to physiological symptoms and psychological symptoms, right? For example, there are people among us who believe that the world is a nasty place and everyone else is against them. And he or she is a useless person. That sort of beliefs, right? Negative, very negative. And the assumption is, even if somebody does good to them, that is because that person wants something else to be done. Oh, we'll wait for a favor, that sort of thing. However, during their day-to-day lives and all, they could compensate because they are managing with their own resources. But there might be a stressful situation. Somebody dies, they might lose the job, or they might face a difficult exam. And in that situation, the anxiety level goes up. And there might be automatic negative thoughts which are coming again and again, right? Nobody likes me. I'm a useless man. There is no future for me, kind of things will start coming, and then they become depressed. So in his theory, these sort of thoughts and behaviors interact with each other and give rise to symptoms. So they need to be changed. That is called the cognitive behavior therapy. From that, there are other derivatives. One is this mindfulness-based cognitive behavior therapy, where to the gamut of cognitive techniques, we have added techniques from mindfulness. So in the mindfulness-based therapies were well described in science, and they come from Satipatthana Sutta. No, why I have put this? Okay. Now, if you listen to this sort of programs, you will hear a lot of theories, lot of concepts, universal explanations. Remember, they might not be true or applicable or mixed with each other. So they serve a different, purpose. This popular psychology, which pops up in these sort of programs, not only this one, there are so many other things. This is very illustrative, that's why I put it. Are full of people who come and explain these things, who does not have absolutely no clinical experience at all sometimes. So be careful. And some of the other things which appear in these sort of things are not useful at all, can be outright harmful. Let's say even relaxation, which we are going to teach you later, is not going to be applicable in some conditions. You need to know why it doesn't work in certain situations and avoid teaching patients relaxation exercises when they don't work. Okay. So there are red herrings and pseudosciences hovering all over the place. I told you that certain Freudian theories and certain theories in psychology are not comparable with hard sciences, like let's say scientific theories in physics or chemistry or even biology. But they have been scientifically studied. Let's take mindfulness. Now, mindfulness was a technique which was derived from Satipatthana Sutra. ඔගොල්ලෝ කියවලා තියෙනවද සතිපට්ඨාන සූත්‍රය? අහලා තියෙනවද? අහලා ඇතිනේ. In that, what the Western science did was extract the technique, purely the technique out of that spiritual context, and incorporated it to the cognitive behavior therapy model of delivering psychotherapy. And they did not stop at that. What they did was they delivered it to a group of people. I can't remember how many. It depends on the research. There are so many. Let's say 50 or 30. And then compared the outcome with another group of 30 people who received a different kind of psychotherapy or a counseling course, which is more or less closely similar but different, and then compare the results. When you do that, that is science. Then there are results, right? That is how the newer techniques were developed and incorporated. Okay. From Carl Rogers' humanistic theory, there is this positive psychology. This is more or less not positive thinking itself, but positive psychology based on realistic psychology. Now, so far, up until, let's say, last 20 years or so, psychologists, psychotherapists, counselors, and doctors, and everyone, psychiatrists, focused on the negative aspects of life. Especially psychiatrists are there to diagnose people and then label them with the diagnosis, illness, and then find some treatment for them. Psychologists do the same thing, counselors do the same thing. When they are not functioning well, we would look for their negative pattern of thinking and identify it and treat it. But on the other hand, the recent developments of psychology informs us if you do the reverse of that, positive side of it, health promotion side of it, that also works. That can be used in our treatment as well. Rather than focusing solely on the negative ways of thinking, behaving, feeling, we can actually use certain other ways of promoting psychological health. For example, let's say you ask in cognitive behavior therapy, we ask patient to keep a diary. And that diary is for what? In that diary, we are supposed to note down the symptoms, appearance of difficult situations, symptoms, problems which we have, and how are we thinking, that sort of things. Then when it is brought, then we ask, okay, you have been thinking about your losses. What was the rating you give your mood? Well, it is 2 out of 10 kind of thing. Negative, 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 right? Later only we start challenging. Whereas in positive psychology, you might ask the patient to keep a diary and use it as a diary to document the things which you are grateful of. We call it a gratitude diary. Every day, you can also try this. Write down 3 things that you are grateful of. Very tiny things sometimes. Even having a good meal. Right? In this country nowadays, there are people who miss their meals on a regular basis because they don't have enough money. Right? Nowadays, even getting 7,000 rupees worth of petrol is something to be really happy of. Right? So that sort of things are there. Or having had to deliver this lecture and to end it in a positive note is something to be happy of. Whatever. So the positive side of psychological life was explored and experimented, researched, observed recently, and is being used in psychotherapy and counseling nowadays, right? Okay, I'm not going to do that, but I will come to some of the other stuff. One is, when we come to psychology and counseling, we come across people who are suicidal. They will come and tell us, I don't feel like carrying on, it's too much for me. I've been having this for a while now. It's better dead rather than alive. And going beyond that also, they might tell you, well, I feel like taking my life, I planned it, I'm going to take poison or whatever, right? So theoretically, counselors, psychologists, and psychiatrists are there to prevent suicides. And they do. We do prevent few people killing themselves, people who come across us, So that's a good thing. And there are other institutions, befrienders associations, helplines. There are helplines in Sri Lanka where you can dial and call and talk to them. Try this. Some of them are really good. People who are trained like you are running helplines sometimes. Other counseling services, all these things. And treatment services, like our hospital, we have a clinic, so we treat people who are suicidal. And then what? Then as clinicians, we come to believe that we do a lot of suicide prevention. Now I have paused. Okay, because that is not the case. We will be preventing suicides of the people who come across us. And that's only a tiny fraction currently, mostly, right? And suicides depend on so many other things: the culture, the belief system, personal predispositions, various other, impulsivity, right? Those things are not prevented by counseling. So improving counseling services and counselors, sorry, haven't I shared this?
No, doctor.
Right,
Now we can.
yeah. So improving counseling services and treatment services will not help prevent suicides, because determinants of suicides, remember that word, that's an important word. Determinants of suicides have nothing to do most of the time with mental illnesses or problems. They have more to do with the culture, mass media, personal predispositions like personality, and the situational factors, which cannot be altered by improving the counseling services or improving the number of counselors. Suicide prevention කරන්න බෑ counseling උගන්නලා. හෝ counseling service. And I think එක ගෙදරකට එකා ගානේ counselors යවන්න වෙනවා. හරි දාන්න. So when it comes to prevention of psychological distress, suicide, and various other things, that's a different territory. Don't go with the idea that we are preventing suicides. As we will be preventing suicides of the clients which we see. That's all. That's a tiny fraction of the total number of suicides. And the way to prevent suicide in whole of the Sri Lanka or the world is sorry, not by increasing the number of counselors. ඒක නිකන් අර අපරාධ අඩු කරන්න හිරගෙවල් වැඩි කරනවා වගේ තියරි එකක්. හිරගෙවල් වැඩි කරාම අපරාධ අඩු වෙන්න එපා. It doesn't happen. Likewise, counselors ගාන වැඩි වුණා කියලා සියදිවි හානි කර ගැනීම අඩු වෙන්නේ නෑ, because යටිතල සාධක වෙනස් ඒකට බලපාන. Those inhabit different spheres of intervention. And there is another aspect to counseling. This might be a very popular picture these days. Counseling is a clinical intervention. උපදේශනය කියන්නේ සායනික මැදිහත් වීමක්. And counseling cannot solve social problems. සායනික මැදිහත් වීමෙන් සමාජීය ප්‍රශ්න විසඳන්න බෑ. සමාජීය ප්‍රශ්න වලට සායනික විසඳුම් දෙන්න යන්නත් එපා. ඒක ඔය TV programs වල එහෙම සමහර වෙලාවට කරනවා. That's why I mentioned it. Don't do that mistake. පහවස්සරේ ශිෂ්‍යත්වයේ ළමයි ස්ට්‍රෙස් වෙලා ඉන්නවා කියලා උන්ට කවුන්සලින් කරන්න යන්න එපා. The problem is a social one, socio-economic one. 1980 පහවස්සරේ ශිෂ්‍යත්වයේ පාස් වෙලා රොයල් හරි විසාකා හරි එන්න තිබ්බ chance එකට වඩා දැන් ළමයින්ට chance එක අඩුයි එන්න. මොකද ඒවයි primary ඉස්කෝල ලොකු වෙලා. Right? So if you take the year 5 scholarship, it's a socio-economic problem. It's not an individual problem that should be dealt with counseling. Of course, we can do, let's say, depending on the child and the mother, or the father and the parent, and even the school teacher and the principal. Sometimes we have to intervene. That is something different. But as a problem, those cannot be solved by counseling. That is a criminal stance that some of the counselors take. සමාජ දේශපාලන ආර්ථික ප්‍රශ්න වලට සායනික විසඳුම් දෙන්න පුළුවන් කියන බොරුව මිත්‍යාව ප්‍රචාරය කරලා යවන එක තමයි අපි කරන එක අපරාධයක්. එතකොට ඒවා විසඳන්න බෑ. But counseling is so glamorous and attractive and fashionable, I should say. People purposefully, without their knowledge, but without realizing that they are doing harm, is trying to actually apply in their own personal lives, as well as propose to be used in these major social, economic, and other problems. So that is something negative of counseling. What do we do, right? Economic problems. Yeah, he's from Bangladesh. Yunus. Now Bangladesh is asking money from the IMF. අපි අහුව වගේම දැන් අහනවා hi. 2 months back, Bangladesh was hailed as one of the good economies. Now they're asking. This man in 1970s introduced the Grameen concept of microfinance banking and was given the Nobel Prize for economics. Because ඇයියාට මේ Nobel tag හම්බ වුනේ? එකත් මේ counseling වගේ මගුලක් ඉඳ තමයි. Right? Because it's not going to work. That is why he got the prize. Because the actual problem is a structural economic relationship between people who have money and who don't have money, which could be distracted by introducing this sort of theories. ඒක තේරෙන්නේ නැත්නම් අමතක කරලා දාන්න. යූනුස්ගේ microfinance banking වලින් ලෝකෙ දියුණු වෙන්නේ නැහැ. ලංකාව දියුණු වෙන්නේ නැහැ. බංග්ලාදේශ දියුණු වෙන්නේ නැහැ. හරි? It doesn't work. There are other things which might work. Likewise, counseling will not work in socio-economic, cultural problems. Don't try to apply that. Problem solving cannot be a solution to economic problems, right? It is there in the system. The system change. Sorry, I should not be talking any politics here. Right. The Road Less Traveled is a book written by some psychologist. I can't remember his name. Scott Peck, as I remember. Yes, it's a good read. It's a pleasurable read. If you have time, find this book and read. Even in counseling, the road less traveled is what? To do the right thing. To learn one important lesson from today's, I will come to that later. Okay, to do the right thing. But if you want to go beyond counseling and help people, let's say, deal with the problems of year 5 scholarships or A levels or whatnot, either you will have to resort to economics, politics, or there are other fields in health which do that, which is there to address the determinants of ill health. Determinants of ill health, which we don't do in counseling or psychotherapy. We will not go beyond the individual level. We will address the individual determinants. But addressing individual determinants will not solve the social problems. What is the most deadly disease in the world? Monkeypox නෙමෙයි. Not COVID, not HIV, but poverty. Counseling is not a solution for poverty. Remember that. And individual determinants, addressing individual determinants will not lift people out of poverty as well. Might lift one person if you help them to analyze their finances, do this and that, and address their own life situation kind of things. They are nice with chance and all sorts of things, but we are not preventing anything by improving counseling services. We don't have that grand idea of helping the whole of Sri Lankan to, reduce suicides or likewise various other things by improving counseling services in the country by training counselors. No, it doesn't happen. I'm giving you the scientific background for you all to understand where we are and where we should not do harm. මම ඉන්ඩිවිජුවල් එකක් කිව්වනේ මතකද? ගහක ඇණයක් ගහලා තියෙනවනේ ඒක ගලවන්න යන්න එපා. So that's an individual harm that you can avoid, right? If there is a traumatic event which you have identified, but there is no necessity for it to be addressed, leave it alone. Don't dig. Likewise, don't try to apply counseling to social problems. But I am telling you, there are other things, other aspects of health interventions. Public health kila field එකක් තියෙනවා. In that public health, there is a field called health promotion, community health. The skills and the theories which are applied there are very different. And the unit of intervention is not the individual. In counseling, what is the unit of intervention? Either individual or the couple or the family. We don't, or sometimes the groups. But still the intervention is clinical. Whatever you do, it's clinical. It is not public health. It's not community intervention. It's clinical. Right? ඒක නිකන් මේ වගේ. මෙතන දැන් ඩොක්ටර්ස් නර්සස් අතර එහෙම ඉන්නවනේ. මම කළුබෝවිල හොස්පිටල් එකේ ඉඳලා ඈත කොහෙට හරි ගිහිල්ලා මේක මම අනුරාධපුර හිටිය කාලේ මම පදවිය ගිහිල්ලා ක්ලිනික් එකක් කරා. So when I was in Anuradhapura, I went to Padaviya, 90 kilometers away from Anuradhapura hospital. 2.5 hours kind of a drive, and then do the clinic and come back. That is not a community intervention as such. ඒක මේ ප්‍රජා මැදිහත් වීමක් නෙමෙයි. ඇයි ඒක මේ ස්පිරිතාලෙම කෑල්ලක් ඈත කොනකට ගෙනියලා එතන ඒ වැඩේ කරලා විතරයි. So those two are two different concepts. ඒ ප්‍රජාවගේ සහභාගීත්වයක් නැහැ. ඒගොල්ලන්ගේ බලාත්මක වීමක් නැහැ. ඒගොල්ලන්ගේ ownership එකක් නැහැ. So there are other methods of intervention in health science which addresses the communities, groups, and geographical areas, which of course are capable of addressing things like poverty, stress, and suicide better than individual counseling. So social economic problems are not addressed. And one other thing which are not addressed is the influence of the industry. Individually, we don't do that. We can't most of the time. But actually the problem lies outside in the relationship that the community has with other forces which are out there. For example, food and beverages industry. ලංකාවේ පොඩි ළමයින්ගේ ස්ථූලතාවය දැන් 15-20 වේගෙන යනවා. 15ට වැඩි වේගෙන යනවා. පොඩි ළමයින්ගේ මහත. එහෙම රටක් නෙමෙයි මේ රට. තිබ්බ විදියට. ඒක මේ එකයි කාලවල කවුන්සලින් කරලා හොඳ කරන්න බෑ. ස්ථූලතාවය අඩු කරන්න බෑ කමියුනිටි එකක එක එක ළමයට dietary advice දීලා. එහෙම වෙන්නේ නැහැ. මොකද ඒකේ යටිතල සාධක වෙනස්. Because there is a huge industry promoting unhealthy food. And when the community cannot handle that, what amount of psychological counseling will not work. Okay, the last bit. As counselors, when you have finished this course, hopefully, some of you at least would have learned a little bit. And a little bit of personal change could have taken place. අපිත් මේක කරලා ඉවරනකොට අපේ පෞරුෂත්වයත් අපේ මිනිස්සෙක් වශයෙන් ලෝකෙ දකින විදිහමත් ටිකක් සමහර විට සමහර අයගේ වෙනස් වෙලා තියෙනවා. හොඳ පැත්තට කියලා උපකල්පනය කරමු. So the personality can be changed. අපේ personality එක වෙනස් කරගන්න පුළුවන්. Especially if you are young enough time, right? Can take place as a result of learning and practicing. but it takes a long period of time, and it takes deliberate practice and fair bit of commitment. Empathy හැම ඉගෙන ගන්න කල් යනවා. සමහර අයට උපතින්ම පුළුවන් ටිකක්. And how to feel for other people, that sort of things, and learning from experience and being a different person. Why I'm telling this? Now I told you one of the most important non-specific factors in improving somebody else is the therapeutic relationship. Can you recall it? Jeremy Franks. So Jeremy Franks therapeutic relationship කියන එක තමයි පළවෙනි එකට ආවේ. ADT, any damn thing. එතකොට what is meant by therapeutic relationship? අපිත් එක්ක රෝගියා හදාගන්න relationship එක. වැරදි. රෝගියත් එක්ක අපි හදාගන්න relationship එක. වැරදි. අපි දෙන්නම එකතු වෙලා හදාගන්න relationship එක මේක. එතකොට හරි. The relationship between us and the patient or the client, which is collaboratively developed in a therapeutic environment, is called a therapeutic relationship, and it depends a lot on us, right? And the patient feels more than anything else, more than what you say, more than what you do, actually what you are. If inside, within, in the deep of our being, existence, if we are not good, that is felt, that is sensed by the patient. If we have taken a position where we feel very powerful compared to the patient will feel threatened. So yes, you are to be a good therapist, well, you yourself have to change. It should take place. It might not take place within a year, but you can start doing something about it. It might take a long period of time for some of us. It's a slow and a deliberate process. Sometimes it takes a lot of courage to help other people. Right? A diploma would be of use, but you know, it's who you are developing now. And the last bit, when we come to counseling or psychiatry or medicine or whatever, all of us want to feel entitled for the work which we do and did. අපි ලෙඩෙකුට බෙහෙත් දීලා හොඳ වුණාම දොස්තර මහත්තුරු නෝනලා විදියට අපිට පොඩි සතුටක් ඇති වෙනවා. අපි දීපු බෙහෙතෙන් හොඳ වුණේ. අපි හරියට ඩයග්නෝස් කරලා. ඒක තමයි මේ සබ්ජෙක්ට් එකේ ස්වභාවය. සයිකෝതെරපි කරාමත් එහෙමයි. එතන හැබැයි තියෙනවා පොඩි බල තුලනයක්. මම කාව හරි වෙන කාගෙන් හරි ලබාගත්ත දැනුමකින් හෝ බෙහෙත් වලින් හොඳ කරනවා කියන එකෙන් මගේ බලය වැඩිවීමක් එතන තියෙනවා. So there is a bit of a power exchange there, or two power positions where the therapist is powerful and the patient is powerless. It happens automatically, and in some instances it is required. It's a must, otherwise the patient will not benefit. But in most instances, towards the end of the therapy, we want the patient to feel what? Empowered, self-sufficient, with full self-esteem and self-confidence. And what will such a patient will tell when he leaves therapy? තමන්ගේ මේ ලෙඩේ හරි මොකක් හරි හොඳ කරගෙන කවුන්සලින් වලින් එළියට යන patient ප්‍රශ්නේ හරි. එයාගේ ආත්ම විශ්වාසය ආත්ම අභිමානය හොඳින්ම තියෙන විදියට නම් එළියට යන්නේ. එයාට දැනෙන්නේ මොකක් වෙන්න පුළුවන්? එයාට දැනෙන්නේ මේකයි. මමම තමයි මේකෙන් ගොඩාක්. then you have done a good job. දැන් බෙහෙතක් දුන්නට පස්සේ patient එක කියන්න අවස්ථාවක් නැහැ. අපි ඒගොල්ලන්ව බල රහිත කරලා ඉවරයි. මොකද අපිනේ බෙහෙත් දෙන්නේ. අපිටත් මහ ලොකු බලයක් නැහැ. අපි මේ pharmaceutical company වලින් හදන බෙහෙත් දෙන්නේ. හැබැයි අපි දෙන්නේ. So there is always a power difference. But in psychotherapy and counseling, the most competent, capable and good therapist will leave the client believing at the end of the treatment that client helped himself. ඒක තමයි එක වැදගත් පණිවිඩයක් මතක තියාගන්න. If you get that, then I have done my job. Okay. Studying counseling, you learn it only by application. This course will be of use to a great extent, I can guarantee you, because people who teach here are practitioners. But if you want to improve yourself, write down what you think. Then when you make a mistake, it is there clearly in black and white to show you that you had done a blunder. And be open to change. And most of the time we might be wrong. And remember, all science proceeded and will proceed by proving that existing theories are wrong. And that is true with the theories which we formulate about our patients. When it comes to counseling, we also formulate different theories about our patients. Their personality, their past trauma, all those things are hypotheses which we develop inside our minds. And we'll be constantly testing them. And he might be proven sometimes wrong. So you need to be open. So you need to learn experience from experience, but you can substitute experience to reading as well. Then you can learn from other people's experiences. You need not read psychology that lot, even classics. Shakespeare's Othello, this drama describes very well about the pathological condition. It's called pathological jealousy. People who have read classics will be capable of understanding human behavior a little bit more because of the language capacity that they have developed to start with. Second thing, these things are not new. They have happened along the centuries. So psychological problems have been there in India, in Sri Lanka, in USA, everywhere, right? So learning from experience, our own is one thing, but you still can learn from other people as well. Right? සුභාෂිතය වගේ එකක් කියවන එක නරක නැහැ. Okay, this I wanted our Sinhala medium student to start reading in English those days, so I was talking to them on how to improve language skills. Anyway, it might take about 5 years for you to develop up to a expected level, expected by the general public of this country, of a good counselor once you finish this course. That when I heard this term, I was startled. When we were in the medical school, one of the professors, I can't exactly remember who, came and told us, the whole batch, well, young ladies and gentlemen, in about 15 years time, this was in the final year, so when you become good doctors, and we were puzzled because we were about to pass out, and then even if we do, let's say, a subspecialty and become consultants, specialists, it might take only another 6 years or so. Why this 15 years? Well, that is the level of that is the duration of time that you might be spending in the subject, within the subject, practicing it in and out to become real experts, expected by the general public. So yeah, continue to learn. And remember, some of us will never be but that is life. Okay, with that, I'm going to stop now. I will not entertain any questions as such because we will be describing these theories in detail in the future. So reserve these questions for the time, let's say, for example, when somebody is teaching you Freudian theories, then you can clarify those things. But I will leave this meeting open, making one of you all the co-host. And then you can continue to discuss among yourselves and come up with the name for the monitor. අපිට කොහොමද monitor කෙනෙක් තෝරගන්නේ මේකට? I don't know. Since I don't know any one of you all, I can't suggest anyone. Let me see. Somebody who has some free time or somewhat organized life. We can't expect someone who had delivered a child last month to become the monitor or someone like that.
Doctor, can I suggest the person who created the WhatsApp group, because he
Yeah,
seems
sure.
to know his technology, and I think he's a
Fine.
student
What is
at
his
the
name?
university.
මොකක්ද නම?
One.
Okay, who created the WhatsApp?
Kitsiri, I think.
Kitsiri. ඉන්නවද අද?
Kitsiri, ne?
Kitsiri is there. So Kitsiri, what
Katugampala.
time? Yeah.
Surname is Katugampala.
Now there is one Kitsiri.
Surname
Kitsiri.
is Katugampala, doctor.
Okay, Katugampala. Because can Kitsiri speak up a little bit so his name will come up. මේකේ Kitsiri කියලා විතරයි තියෙන්නේ. Hello Kitsiri, are you listening?
Yes, I am listening, but Katugampal is the one who created the group.
Okay.
I think he is a student at the